Welcome to Policy Punchline. Here on the show, we interview scholars, policymakers, and business leaders on the issues shaping public life today. I'm Alice McCarthy, co-president of Policy Punchline, and I'm joined by my fellow Policy Punchline host, Aiko Offner. Our guest today is Chiquita Brooks-LaSure. She served as administrator of the Centers of Medicare and Medicaid Services from 2021 to 2025, leading the agency that runs Medicare, Medicaid, CHIP, and HealthCare.gov for more than 160 million Americans. Before that, she was a managing director at Manatt Health. And in the Obama administration, she worked at the Department of Health and Human Services on the implementation of the Affordable Care Act, including the Center for Consumer Information and Insurance Oversight. She has also spent time in Congress working on health coverage policy, that she has seen U.S. healthcare from every side: legislative, executive, and advisory. Chiquita, thank you so much for joining us.
Thank you for having me.
Okay, so our first question, we're going to start simple. In layman's terms, what does the Center for Medicare and Medicaid Services actually manage and do? I know you manage a very large budget, employ a lot of people. How does your work there affect an ordinary person's healthcare?
CMS, the responsibility of the agency has really grown over time. It is responsible for, I like to say, the three M's: Medicare, Medicaid, and marketplace coverage. So that is combined the coverage of 1 out of every 2 Americans. And so the role of the agency when it comes to each of those programs is really important. Medicare, it does a couple of things. Medicare is both traditional Medicare, where the agency pays the claims for when you visit the doctor, when you go to the hospital, and is responsible for making sure doctors and nurses and hospitals and other providers get paid. It also oversees the coverage for people who are enrolled in Medicare Advantage. So people who are enrolled in private plans who have to meet the standards of Medicare. CMS is responsible for making sure they meet all of the requirements. CMS is also responsible for Medicaid. Medicaid is a program that is jointly managed between the federal government and states. A lot of the role of CMS is making sure that the states are meeting the standards of both the law and the requirements that CMS sets forth. For the Affordable Care Act coverage, marketplace coverage, CMS is responsible for working with health plans to make sure all the offerings are on HealthCare.gov or state-based marketplaces, and making sure that the coverage meets all the requirements for people to get access to the care that is provided. That is a lot of the work of the agency, but it does many other things too. Some of this is lesser known as the responsibility. So CMS is responsible for the health and safety of most of the facilities across the country. About 20,000 nursing homes, hospitals, et cetera, have to meet standards that CMS sets in terms of making sure that people are getting the care that they need. That is one of the ways that CMS's role can be larger than even the coverage that it is responsible for. For example, during the COVID-19 pandemic, a lot of the things that you think about that were done by the federal government, the standards really were things that CMS was responsible for. So that in large part is a lot of the work of the agency, really overseeing and setting the rules for a lot of the coverage that Americans get. Also, again, with the health and safety standards can have even more implications for our larger healthcare system.
Let's talk about one of those everyday impacts: getting covered in the first place. Open enrollment for 2025 hit roughly 24.2 million people choosing marketplace plans. In human terms, what did you change that helped get more people covered?
God, I'm incredibly proud of the work that we were able to do during the Biden-Harris administration to really lower the uninsured rate and get it to the lowest it's been in our nation's history. And a lot of that was through ACA coverage. When I came into the position, there were about 12 million people covered under ACA coverage. And what changed during our time were a couple of things. One, we put incredible emphasis on outreach and enrollment, particularly I think what I would call harder to reach communities. So there are many people who get their coverage looking at the website or through brokers who are people that help people enroll. But a lot of communities need what I would call trusted messengers. And those were people that we would contract called navigators. And I think that really helped educate people about in some of the communities that were less likely to enroll in coverage. So we put a great deal of emphasis on harder to reach communities, really upping our outreach. So things like media and radio, and trying to make sure that we were working hard to raise awareness. I think that made a huge difference. What also made a significant difference was an increase in the subsidies. And that is something that, just to back up for a minute, Affordable Care Act coverage, the Affordable Care Act changed the rules about insurance coverage, took away discrimination. It took away some of the rules that would allow men to be given rates lower than the rates women were given. But part of what it also did was subsidize that coverage. All of our coverage in America is subsidized by the federal government. Those of us with employer-sponsored coverage, both we as individuals and employers get a tax break. Same with Medicare and Medicaid, that it is subsidized. The ACA subsidizes, the law subsidizes coverage too. During the beginning of the COVID pandemic, the government subsidized that coverage at a higher rate. Democrats during the Biden administration extended that coverage. That happened during my first year as a CMS administrator, and we immediately saw a jump in the number of people who were enrolled in coverage. And I think that increased affordability, the work we did to improve our outreach and make it easier for people to enroll, combined with making it more affordable, really led to record levels of enrollment.
Yes, totally. That is definitely a very impressive feat. But you did speak about harder to reach groups and also the increased coverage under COVID. I think a lot of this coverage momentum kind of ran head on into Medicaid's unwinding. And after the pandemic, millions had to prove again that they still qualified for Medicaid. So, in simple terms for this, what worked, what didn't, and most importantly, what permanent fixes are you putting into place so people don't lose coverage just because of paperwork? And how will the new streamlining eligibility rules change renewals for people on the ground who are actually experiencing this?
So during COVID, just as you said, I would say the country realized how important it is for people to have coverage, right? Because if we go back and think about that time, it was really important to make sure if someone had COVID that they were treated. And for a short period of time, there was this real appreciation in our country of how connected we are. As a result, Congress passed laws to make it easy for people to get coverage and to make sure that they stayed on coverage. What ended up happening when the COVID rules expired was that we went back to business as usual. And I think the real key lesson is that the rules are more complicated than they should be. We saw during what was called unwinding of having people having to go through the process that some people who should be covered were losing their coverage. Some of that is the result of systems that don't talk to each other as well as they should. Some of it is that our rules in this country continue to be more complicated than I think they should be. One of the things we did in the Biden administration was to set standards to really try to streamline eligibility and make it simpler. Unfortunately, this year, a lot changed. And so those rules that we put in place were repealed by HR 1, legislation passed by our current Congress in 2025, which by reducing those rules or repealing those rules and adding additional requirements, I think we are moving in the wrong direction, making paperwork more complicated with not only additional requirements, but also where people have to do eligibility determinations more frequently. So moving to every 6 months, which is a huge burden on people in terms of paperwork. And again, one of the things I think I would say about our healthcare system overall is that we have too much friction in our healthcare system, both in terms of getting enrollment, getting enrolled in coverage, as well as when you have coverage, the hoops you need to go through. And so I am very concerned about the direction we're headed in.
Yeah, thank you for that. I wanted to ask, I know you worked on dual enrollment a little bit when you were on the Hill before you came onto CMS. Can you talk a little bit about that? Because that also seems like a bit of an administrative issue and mess that is difficult to untangle. So can you talk a little bit about that and how your work on that might have influenced your ability to streamline some of the processes as director of CMS?
Yeah, so there are many people in this country who are both enrolled in Medicare and Medicaid. And Medicare is a program that is designed for people who are over 65 or who have severe disabilities. Medicaid covers people who have lower incomes and fall into categories where they have particular needs. A lot of people who are over 65 and who are low income are either fully or partially getting coverage through Medicaid. I would say a couple of things about coverage. Medicare covers a set of services, but there are some crucial services that a lot of seniors depend on that are only covered by Medicaid. I'll give you a couple of examples. So, nursing home care in our country is only partially paid for by Medicare. Medicare only pays for what we call skilled nursing coverage for about 2 weeks. And so, people who are in nursing homes longer term, Medicaid is primarily paying for those set of services or private pay. So people, paying out of their own pockets or if they have long-term care insurance. So there are a lot of, and the second crucial service for a lot of dual eligibles is home and community-based care. So if you want to stay in your community, Medicare only pays for home visits in extremely narrow instances. The home and community-based services are largely paid for by Medicaid. And then finally, Medicaid helps seniors pay for cost sharing. So things like the Part B premium and copays. Medicare has roughly a 20% copay for a lot of services. These are really crucial services for people who are dually eligible for both programs. But sometimes when you have two different payers, the costs can be, changes you're saving on one side don't necessarily translate to savings for the other. And so ideally, you really want, and the other thing is that enrollment in the cost sharing is done at the state level, but the state is just paying for co-pays. They're not seeing the big picture. And so what we've found is that enrollment in many of the cost sharing programs for dual eligibles is much lower than what we would expect it to be. And it's a lot lower than enrollment for things that CMS or SSA are responsible for. So that's a long way of saying one of the things that we in the Biden administration really tried to do was work to really increase the number of seniors who are enrolled in these services and make it easier. Again, just as I was describing, you're enrolling separately, so it can be confusing for a senior who is eligible for both to even be aware. The incentives are not always ideal. For example, you can be a dual eligible enrolled in two different health plans, one through your Medicaid managed care, one through your Medicare Advantage plan. These are some of the big issues for dual eligibles. I think that a lot of my perspective on duals actually comes from early in my career. When I first was starting, I worked at the Office of Management and Budget and saw firsthand a couple of state demos in Minnesota and Wisconsin, who were a couple of the first states who really tried to coordinate care between for dual eligibles. And this was in the early 2000s. They were really on the forefront of thinking about how to coordinate care. And I think that this is one of the biggest issues really facing our country, how we think about long-term care, especially as the baby boomers age. And we struggle with, uh, we as a nation, with how Medicare costs are growing. And I think that we as a nation really need to wrestle with how seniors, as they age, how we're taking care of the care that they need in a way that is both fair to the people, like really making sure people can stay out of institutions if that's appropriate, like if they can get the care in their homes and in the community, but in also a way that's financially stable for our country.
So CMS has the authority to, let's just say, enact change broadly through Section 1115 of the CMS code, so through waiver in Medicaid, and then also through the Innovation Center. So what are your thoughts on the limitations of that? What have you been able to do? What are some frustrations you've encountered during your time there and now that you're away as well?
Yeah. So I think the way the law works is there are a set of rules for Medicare and Medicaid, but there is this real understanding that we need to be able to innovate. And that's really what the Innovation Center was born out of during a time when costs were going out of control and policymakers were really concerned. And so they gave CMS authority to implement demonstrations and models to try to do some things differently. And I think the Innovation Center has been able to do some incredible things that move to the core of the Medicare program. And one of the things has been accountable care organizations, where there's been more of a thought about, can we move away from fee for service and just paying for services and really try to move more to better coordinated care. During my time, one of the things I really wanted to focus the Innovation Center on is really making sure that we had a lens of trying to make sure that our models really encourage participation from providers that often serve harder to reach communities, because some of the models were doing really well for particular communities, but not reaching all of rural areas or providers who serve the underserved. So one of the things that we really emphasized, for example, in the ACO REACH model, which is an ACO of really trying to encourage the ACOs to contract with providers that serve underserved communities and to make sure that there can be participation broadly. It can be challenging, though, to provide care in this way, particularly for harder to reach communities when you have strict rules about needing to save costs. And so sometimes um, some of these models have been challenging for different providers to participate. And that's, I feel like some of the limitations of the innovation center models. And I would like to see some of our models to really focus more on improving quality of care, as well as needing to be budget neutral to save money. Because sometimes you need to put more money upfront into healthcare and you might not see those savings immediately. And I think that's one of the challenges of models that tend to be needing to be budget neutral. That's usually the way we operate them in a short period of time, because some of the investments we need to make in healthcare, particularly around primary care and preventive services, may not achieve savings in the short run. But I think, the Innovation Center has been a great way to test new things. And some of our focus during my time were on things like improving maternal health, the guide model, which really is focused on people with dementia and making sure that their caregivers have additional support, which is one of the ones that I'm really very proud of and very excited about. And then you asked me about 1115s, which are waivers that are given to states to run the Medicaid program. Most states have 1115 waivers and have done something different in their states as they implement Medicaid. During my tenure, a lot of our focus in 1115s was really trying to provide additional benefits. I like to call them healthcare adjacent. So, really focusing on short term housing and food insecurity, as really many states really wrestled with the fact that in many critical cases, it actually makes sense to provide some of these ancillary services. For example, if you're dealing with a homeless population and you take care of them in the hospital, putting them immediately on the street isn't going to lead to a good health outcome. So, should Medicaid provide short term housing support? And that's something that we saw many states become very interested in and look to 1115s as a way to offer those ancillary benefits.
Thank you. Yes. Building off of that a little bit, you talked about how Medicaid can help. Through 1115s, Medicaid can cover some of these, like what we would call social determinants of health. So housing, food, things like that. You mentioned once that you think that we might be relying a little too much on 1115s to grant these additional benefits, which are imperative. So moving on from that, what are your thoughts on so much of these benefits being administered through 1115s? And what is an alternative to that?
I think a couple of things about this issue where I think that there is clearly an understanding and a link that we can't just think about healthcare and health only about going to the doctor and getting care for providers. There are related elements. But the question is, who should be paying for those related elements? And I think that Medicaid is one of the biggest expenditures in the federal government and certainly at the state level. And it's an entitlement, meaning if a state is spending the money for a set of services, those dollars continue to flow. There's also pots of money that are meant for food insecurity and pots of money for housing. And if we replace those dollars with money that's for health services, it puts a pressure on the Medicaid budget. There is a balance of whether or not some set of services should be paid for by healthcare or should they be paid for by other funding. And I think that is the tension. We just had a big cut to the Medicaid program right now over the court with HR1 passing. It's going to put a lot of financial pressure on states. And so one of the things that I think and what drove that are the costs that we as a country are spending, right? And there was a decision by our current Congress to cut Medicaid spending. That is the tension of how much we're spending on healthcare. And that is what I think is some of the challenge with how much Medicaid is paying for social determinants when now we're in a place where some core benefits that are clearly healthcare are not going to be adequately funded. So that I think is the challenge that states are going to be grappling with for the coming years.
Circling back to one of your models that you implemented in the time that you were administrator of the CMS, so the Transforming Maternal Health model was just launched in 2025. Can you talk a little bit about the importance of enhancing access to community health workers and doulas and midwives, these non-clinical practitioners, what they can do for certain communities, and the importance of bringing them into the medical sphere?
Yeah, so I think it's so important to start with understanding that we have a maternal health crisis in this country. It is really shocking how many women have poor health experiences at birth, and many of the deaths and increased morbidity, meaning you don't die, but you have compromised health, is quite shocking. Many of these differences are along racial lines. Black and brown women are 3 to 5 times more likely to die in childbirth than white women, even without a high school degree. And so we see these differences, even if we take into account income disparities, even if we take account coverage issues. So it's not just an issue of being low income. We're seeing severe racial distinctions across this country. In terms of maternal health, one of the things we know is that many of the issues are missed symptoms, and doulas and other community health workers can be a key part of making sure that women get the care that they need, that they get care earlier than because what often happens is that women who have negative postpartum outcomes didn't get care early in their pregnancy. And also afterwards, we see at least 12% of the deaths actually happen after the postpartum period. So maybe 2 months after women have given birth, we still see mortality and morbidity. That's a long way of saying that these supports, like doulas, can be really crucial to making sure that women have help pre, during, and after giving birth. And that is one of the reasons the research really bears that out. And that's one of the reasons why the model put so much emphasis on really trying to bring in these additional workers that really help address women postpartum.
And here you have just talked about inequity in the maternal health space, but looking more broadly, in your CMS framework for health equity in 2022 to 2032, you really promised to put equity at the core. If you could choose one metric that the public should track for the next 3 years to know whether it's getting fairer, what is something that you think we should look out for?
I think it's really important that we make sure that we are looking at outcomes, really distinguishing them by race and ethnicity. And that is something that we very much prioritized, making sure we're collecting this data. And so maternal health is very close to my heart because it was a place of incredible emphasis and where we know we have disparities. But I think it's crucial across any healthcare outcome that we care about, that we are asking the question of are there differences that we see in our community and in our various communities? And so I would say for everything that we are trying to measure, we really need to make sure that we are stratifying that data by race and ethnicity, by geographic location, which is a very important indicator. Your zip code is probably the most important indicator of what your health outcome will be. And it's crucial that we continue to look at those types of measures.
Totally. And for our final question before we wrap up, I would like to pivot to the present. So you were the director of CMS during the Biden administration, during which the government was threatened with a shutdown many times, but narrowly avoided it. How have you prepared for shutdowns in the past in any of the roles that you've had? And what's it like to actually go through it now?
Yeah, shutdowns are very difficult. Was I actually was working as a federal official during two shutdowns in the Obama administration. One was very, very short. We left work on Friday, and this budget passed in the middle of the night. And then during the Obama administration, we had a shutdown. I think it was 17 days of in 2013. And as you said, there were several times where during the Biden administration, we thought we were going to deal with a shutdown. Whether you're shut down or not, you have to do the same work. One of the things that makes the shutdown incredibly challenging is work continues for some people, depending on their funding, some people, depending on what their work is, and some people, even if their work is very important, stops because it doesn't fit in one of the first two categories. So the first one, and this is true across the agencies, across the government, and it's certainly true about CMS, is how you're funded. If you're funded on what we call no year money, meaning it is not funded from an annual appropriation, you continue to work and you can continue to do your responsibilities. CMS is funded, about a third of the people who work at CMS are on no year funds. So they continue working regardless of a shutdown. And again, it's not necessarily how important your work is relative to other people. It's just how it's funded, how the Congress decided to pay for your work. The second group of people are functions that are essential and things that are considered things that would, if that person wasn't filling that role, would threaten the health and safety of the nation. And so, really identifying all of those people, identifying all of those activities is something that every agency goes through during a preparation of a shutdown. What are the functions that we believe we have to do, regardless of whether or not they are funded? Because those are things that need to continue. And then people who don't fit into either of those categories are sent home. It is, I think, a really stressful time for agencies and a big process to put everybody's work into those categories. Administrations make different choices about how they run a shutdown. The way that the choices that we made in the Obama administration looked very different, or different than what the shutdown looked in Trump 1. And this shutdown right now in Trump 2 looks very different than the shutdown in Trump 1. It gives you a little bit of a sense that there is discretion in how you handle a shutdown. I would say some of the things that we are seeing now have never been seen by shutdown behavior. For example, cutting off SNAP benefits is something that no administration has ever interpreted the law to say that SNAP benefits should be cut off. So again, it's an example of different administrations making changes. But I will definitely say, having prepared and been a part of it, it is very challenging for people who are dedicated to public service. That's why they work for the federal government. And it's really hard, I think, to see colleagues who fit in the first category where they get to continue working just because, of the way that they're funded, and just those challenging dynamics that you have during shutdown periods really are hard, particularly when people who fit in the second and third category don't get paychecks, whereas those who sit in the first category do continue to get paid.
Thank you. Speaking of careers in public service, your career as a civil servant, for the large part, has been focused on expanding access to healthcare. And right now, tax credits that would cause premiums to skyrocket, and by that virtue, probably restrict access to healthcare for millions of Americans. I saw a number 24 million people is at the center of that debate. For you personally, what is it like to see that expansion and progress threatened? And in the face of that, and if that does end up happening in different ways, whether it's through this or HR1, what steps must the US take in the face of this regression?
I was so proud of what we were able to accomplish during my 4 years as CMS administrator. And as you said, I feel like it was an incredible culmination of everything I've worked on, starting with the CHIP program, expanding coverage for kids when I started my career. That was the first program that I worked on. And I'm really passionate about it, mostly because I think that healthcare coverage is the core of improving our lives and our ability to take part in the American dream. If you don't have your health, you cannot have life, liberty, and the pursuit of happiness. And so I am very proud that at the beginning of the year, we had reached the lowest uninsured rate in our nation's history. And I'm very sad that a lot of that progress is threatened by HR1 and the expiring of the subsidies. And I think a, a discourse that suggests that only some people deserve to have health care, which I think is what saddens me the most, that we have moved away from what I thought was good progress to realize that the healthcare system, we are all very much dependent on and connected when it comes to healthcare. Healthcare is a fifth of our economy, and we all deserve a better healthcare system. And I think making sure that people are covered is a key part of that. And I think, to me, that was a lesson of COVID, how important it is, if whether you had COVID or not, you were affected by the fact that other people had COVID. You were affected because the hospitals were overwhelmed by people having COVID, and surgeries were delayed because hospitals were overwhelmed by that. And so I think coverage is incredibly important and important for our healthcare system. And I truly hope that during this difficult time where we're seeing some of those things rolled back, that people appreciate how important it is that everyone has coverage, and that we soon pivot to actually tackling the real issues of healthcare, which are controlling costs for individuals as well as the entire healthcare system, instead of fighting over who is deserving of healthcare in our country.
Chiquita, thank you so much for joining us today and talking to us about the importance of healthcare for everyone in the US, and for breaking down these policies and how they actually land for people, from keeping Medicaid coverage to maternal health to pushing towards greater healthcare equity. I think it's really easy to talk about healthcare in the abstract, but it's much harder to run an agency that pays bills for more than 160 million Americans. And I think you've given us a really rare window into what that work looks like. And that concludes today's episode of Policy Punchline. Thank you to our listeners for tuning in, and we hope you'll all join us next time. Thank you, Chiquita.
You've been listening to Policy Punchline, a podcast generously supported by the Julius Rabinowitz Center for Public Policy and Finance at Princeton University. We would also like to encourage you to follow other podcasts produced by Princeton University, such as Politics and Polls by the Woodrow Wilson School of Public and International Affairs. Policy Punchline is intended to be informational only and does not reflect nor represent the views of Princeton University or the Julius Rabinowitz Center for Public Policy and Finance. For more information on subscription, donation, volunteering, or contact, please visit policypunchline.com. Thank you again for listening.